Welcome everyone, Prediction Models and Metrics. This is DIMH 2021, here with some expert panelists with very different lenses and areas of expertise. So I welcome all the delegates coming into the room and especially, of course, the panelists who have taken time to be here with us today. So what I would like to do initially is just to take 10 minutes or so just to get to know each of the panelists. So in a minute or two, if you could just describe a little bit about your background and your affiliations and whatnot. So we'll start with Mandana, if that's okay.
Sure. Hello, everybody. I am Mandana, CEO and co-founder of Alena. It is a mental health startup where we are trying to automate real-time solution to mental health problems for people. I have a PhD in computational neuroscience with a minor in machine learning, and that's the expertise that I'm bringing to Alena. Becky, you're on mute.
too many windows open. Lucia, over to you.
Hello, I'm Lucia. I am a freshly graduated PhD student from the University of Edinburgh. I worked in the Edinburgh Natural Language Processing Group. So my PhD concentration was to extract information from social media text and infer social media users' mental illnesses symptoms. And I use a variety of techniques, including qualitative analysis and a lot of machine learning techniques as well.
Okay, great. Julia?
Yes, hi, hello, I'm Julia Ive. I'm a research fellow in multimodal machine learning at Imperial College London. My background is both in linguistics, computer science, and machine learning. Throughout my path within NLP, I have been working mainly with text generation problems. So these are machine translation, text summarization, and also recently mostly text generation, synthetic text generation to address the data sparsity issue in the clinical NLP domain in general, and more specifically in the mental health clinical NLP.
Thank you. That is a hot topic. Jorge, over to you.
Hi, everyone. My name is Kirk Palacios. I'm a senior digital health scientist at SilverCloud Health. My background is in medicine, and then I did a master's and PhD at King's College London. My PhD was in the area of psychological medicine. And for the past 4 years, I've been working with SilverCloud Health, a company which delivers digital behavioral therapeutics. And I guess the reason I'm here is partly due to our work with Microsoft Research Labs in Cambridge, where we've developed a prediction model, jointly developed it. And now at SilverCloud, we're going to implement that and test that out in the real world. So don't know a lot of the technical stuff, but hopefully I can bring a little bit of the impact and implications bit into the discussion. But yeah, great to be here.
No, we need that. Good stuff, Jorge. And over to you, Matt.
Hi, my name's Matt, and I'm a recovering accountant. So I got into research as a patient, and I'm finishing my PhD, hopefully, at the Institute of Mental Health in Nottingham, where I've been working with MindTech on looking at measures of patient activation in therapeutic conversations. And I work with HD Labs, which is a startup on conversational intelligence. So we're looking at how can we gauge the quality of online conversations amongst the different actors.
Okay, so thank you very much. You've met your panelists now. The format that we're going to use is I will do sort of micro interviews with each of the panelists, around 5 minutes or so. Please drop your questions in the chat because hopefully we'll have time for a bit of a Q&A at the end. I will resist, as a data scientist, I'm going to resist my comments because I have the pleasure of speaking with the panelists anytime. So we're going to start with Mandana, and we've got 2 questions, and I've got to be fierce with time. So here I go, timer. Right, my first question is, what are some of the dangers in making definitive decisions based on modeling these outcomes? And how could this have potentially catastrophic or less than that consequences for real people's lives?
Thanks, Vicky. This time I was on mute. I think that is a very important concern to have, and it is known as AI or machine learning biases, where most people think when we kind of like have a model of something, then it can do miracles and tell us things that we don't know. But in reality, a model is a representation, it's a description of assumptions of the theorist about the causes and correlations and the data that's out there. So the theory, this is like how a theorist understands things relate to each other, and then they build a model that would then, when you put data in, it outputs it. And the hope is that it becomes self-consistent, which helps us then think of the model as a true, like as close a representation to the generative world around the person. Now, the problem here is, if we rely too much on the model as being a true representation rather than just an assumption, then we run the risk of making decisions as if we know what's going on, which can then have real impact on people's life. For example, there was this work that they did, that they were trying to use these AI models and algorithms to allocate police forces for, I think it was the state of New York or somewhere like that. And then they realized things are just going wrong. They get allocated to the wrong places because it became a self-fulfilling prophecy. And it took a long time for them to realize, like, okay, they actually are not helping the crime as much as they thought. So this is one. And then another problem also is about this, again, reading too much about the output of the metrics as being the true measure of what's going on. So for us, so that metric is kind of like an estimate of the meaning of the data and how it changes, right? But for that, you need to sample. You need to keep sampling from the environment for your estimate to become more and more accurate. Now that starts with the assumption that the environment is not changing. So every time you sample, you're sampling from the same exact thing. So therefore you become more and more sure of yourself. But tell me, what part of this world is static? We live in a dynamic world that changes, especially when we think of people's mental health. Things change by the minute, not only the person, but their environment. So then there is this sampling bias that we will always have problems of, where we understand things in a static way in a dynamic world. So we always need to include that when we try to kind of interpret the output of our models and meaning of our metrics before we make judgments about people. I think it's important to always include the person and their feedback as a way of sanity checking. Not that we should rely on it, but it is a sanity checking, because they are the only ones who can tell us, like, does this make sense? And unfortunately, sometimes people think these models are like, they're the gospel, they know it all. And they don't listen to people who say, look, this has nothing, this is not representative of me. No, the model said so, so it should be. So it can be quite catastrophic because of this mismatch between the limits of the model and the metrics and the complexity of life.
Okay, I'm going to dive deeper into this because we're talking about representativeness, yet also data minimization. So how do we, and sampling bias? So mix those all together and it's kind of a disaster.
It is.
but how do you, because on the previous panel that we just had, we talked about PHQ-9 versus PHQ-8. And if you find your effect sizes, drop the 9th question. So data minimization is powerful, but yeah, mixing it in that combination is quite intense. So what do we do?
I think this is an open question. And I don't think it is only about mental health. I think this is an open statistical question that even when it comes to robots or weather or whatever, like whatever dynamical system that we have to deal with, this is an open question. At least our approach at Alena is that we are aware of the limits of our interpretations. So we never make any kind of, oh, and this is the case. So there's a difference between saying the cause of something, our model predicts this is the cause of something, versus our model predicts there's a correlation, which could be changing. keep an open mind on that. So data minimization, I think it's that awareness is the core to everything, and having that but always lurking around, so that I'm being open to not only getting narrow focus on the kind of data we collect, but kind of a multidisciplinary approach, which I think is becoming more and more a common theme between people who gather data, a hypothesis-driven approach, so that when we collect our data, we understand exactly what we are collecting, its limits, and what the model can do, and then be wary of the claims we are making. I think that's the best we can do right now, because it's the nature of statistics, right?
Okay,
right. If in a static world, it would be easy. It's dynamic. We don't know what is the generative machinery underneath this dynamic system.
I hear you.
Very, very complicated. We just need to be careful in making assertions.
Okay, I totally hear you. And I got carried away as a data scientist, so I got to pull back, and that's 5 minutes. But over to Lucia. So, and again, anyone can answer these questions as we're kicking around stuff. So, yeah, framing this through your academic research, and congrats on the PhD. What's your opinion on using algorithms to predict people's mental health status? And do you think these technologies will be helpful in the future?
Yeah, thank you for the question. So for using this technology is pretty new. It's just started a few years ago. So there's still a lot of space for improvement. First of all, I would like to talk about, like, for a prediction model for people's mental health status, the gold standard for this mental health status is very important. Like, how do you know this person actually have a mental health problem? But in academic, most of the papers that work in this use like some self-report measurement scales to measure whether a person have mental health issues. But that's not accurate. So this is one of the problem. We don't have, it's very difficult to gather so-called like gold standard annotation or gold standard label. We don't say label for annotation for mental health status. This is like one thing. The other problem is actually Mandana has mentioned it, that the problem of the prediction model is one of the problem is the sample size. So in most of the academic papers, the models are actually not be able to use in real life because the sample size is just too small. It contains like hundreds to thousands of cases of in the prediction model, and these samples usually contain people of certain ethnicity or characteristics. So when using machine learning in real life, or like building a model that is actually applicable in real life, is super difficult actually, because we need a large enough sample that this sample contain all the characteristics of the new incoming cases. If you want to use this model in new cases, it should contain all the characteristics of these cases. And it's very difficult to evaluate if your sample is big enough to do that. So it takes a lot of resampling and re-experiment to try it out. And so far, I think for academic papers, it's still a bit far away from that, because most of the publications is based on hundreds of samples. So that's why when we interpret the model, we have to be very careful that whether this model is actually being able to use in real life, and what are the biases in there. That's very important. And another thing, my opinion on using algorithm to predict mental health status is there are not enough human interaction studies to interview users. Like, users could be the people who have the data, like social media users, if you use their data to predict their mental health status, or patients who went to hospital and have a patient history, right? Do they actually like this model? Do they want them to predict them, but make a diagnosis? Or interview clinicians. Do clinicians think these models are actually useful to them? Now, the reality is a lot of the human interactions studies has already found that people actually don't like the model to predict their mental health status. Now, they would prefer the model to help them to monitor, for example, some mood fluctuation some of their characteristics that might be related to their mental health status, but not exactly giving a label to them, because people think that, oh, how do you have all my information that is accurate enough to know my mental health status? I don't trust the machine that much. So this is something we need to think about, like before we build a system, do you think the user would like to use it? User not as in just like the end user, like it could be for a human-centered system, a user a human could be in the model, in the machine learning pipeline, human as like one of the decision maker in one of the steps. So for example, a clinician who uses model would know or would see, oh, the prediction result and how does that result influence the decision of a clinician. That is also an important thing. Do you think the clinician think the system would produce somewhat accurate information to them? So this is like what we need to think about as researchers. So yes.
So Lucia, let's go deeper into the ethics here. So,
Mhm.
and let's get hands-on with some examples. So like we're facing diagnostic criterias and that sort of labeling.
Yeah.
But there's this kind of a digital labeling where if you label someone as high risk for suicide, this could have huge implications for their life. So if they are having a surgery, they might, decisions about opioid treatments might be tailored, or just a million different scenarios. Can you get a bit concrete in terms of like other examples of how mislabeling people, it could impact their daily lives, especially around social media data?
Yeah, thank you for this question. It is very important though, like especially for suicide prediction. I think a few years ago, there is a system on social media platform, I forget whether it's Twitter and Facebook, one of them, that they actually produce a prediction on based on their social media posts of whether this person have a suicidal risk. And the worst part they did is to notify the friend of the user. And now this, of course, the user wouldn't like, they won't want people to know the status. So one of the ethical issue of using social media data is, first, you need to obtain approval from the user. Like ask them, give them a clear picture of what you're doing with their data. Do they agree with you of using their data to make a prediction of their mental health status or whether they will have risky behavior? Ask them, do they like to share this information with other people? I would guess most of the people wouldn't like it. So we have to be very careful about that. And also social media data is like viewed as like some gray area. Like some researcher who think that, oh, it's public. If it's anything is public, that means you want to share, you want like other people, you won't mind other people to read it. Sure, they wouldn't mind other people would read it, but they mind that you use their data to make a profile and send this profile to other people. Now, this is a different thing. So especially mental health issue is very sensitive topic. If it's marketing, most of the people would probably accept that, oh yeah, you can use my data to do advertisement. But when it comes to diagnosis and prediction, it's a different thing.
Okay.
So yeah, researchers need to obtain approval. That is very important. This is also goes back to why gathering a large, super huge sample is difficult, because we need to ask every participant, do you want us to collect your data for this purpose, using for this kind of research? And this is also why most of the researchers only got like hundreds of samples, because they only be able to like send out approval for like this batch of people. If it's like millions, it's difficult to handle. And also the measurement scale as well. If they gather so-called gold standard annotation by measurement scale, they need to send out a scale, obtain approval. For a million people, it's also very difficult. So I know that there were projects that is aimed for enlarging this sample size at the moment. There's a project from Maryland University, from Philip Rinsick, that he's actually having this huge database and trying to gather measurement scale from people and their social media data. And they do have a clear description of what is their research and how are they going to use the data.
Okay.
And they do have a pretty secure online cloud that only people who researchers who apply to use this data can access the cloud. So they can't download the data.
Lucia, what you could do is pop that in the chat, because I'm sure Phil would love to promote the Amazon Cloud Service stuff. But yeah, that would be really cool. And I'm just going to be conscious of time, and to make that point about the profile of the low suicide risk, high suicide risk, what happens when their profiles are the same, and how you can't tease that apart in the data. But I think we're going to now just switch course. We've had quite a ethical, cautious, measured optimism perspective so far. We're going to kind of switch to something that's very different in a way, to unique, maybe people haven't heard about this, but synthetic data. It's equally frightening, and potentially it could solve a lot of problems, right, with our undersampling, etc. So over to Julia. Just have a question. What are the problems of healthcare prediction models that can be addressed by synthetic data? So for example, like clinical natural language processing.
Yes, thank you so much, Becky. I will share my screen so that I make my presentation a bit more visual. I hope that will clarify certain parts, because I will be also presenting a bit of methodology. So as I said, I work in NLP. So this is automatic natural language processing, automatic processing of natural language for a task. And the tasks, NLP task, could be related to generation. That's basically what I do. Mainly is the synthetic text generation, machine translation, summarization, and NLP task could be also related to analysis. So this is also what I have been doing throughout my career. Tasks as information extraction and diagnosis detection, or detection of mental health issues and social media. So in terms of the synthetic texts or synthetic data, I believe that they can potentially tackle the following issues of healthcare AI. So this is data sparsity as naturally occurring, as the sparsity also due to privacy concerns. This is also reproducibility, ethics, and interpretability. So let me first probably try to illustrate the process of synthetic data generation with example of the methodology that I proposed recently, and then I will speak more a bit those challenges and how they could be tackled by synthetic data generation. So the methodology I will be talking about is the one that I proposed 1 year ago in a paper that was published in Digital Medicine, in a nutshell, my approach is guided by the generation. In my approach, the generation of clinical text is guided by key phrases extracted from real clinical text. So imagine we have the real text related to mental health issues here, for example. We extract some key phrases from it, then those key phrases are input into the text generation model. And then the text generation model generates some paraphrasing context around those keywords. So as you can see, there is a difference between the real text and the synthetic text, with the exclusion of the keywords. So the keywords stay and the context around them changes. And then in terms of the utility of this text for NLP, what I have proposed to do in this paper is to build NLP prediction models, both with real and synthetic data, and compare their performance, which demonstrated similar changes from one model to another with both real and synthetic data, demonstrating that synthetic data is useful for NLP models. So in terms of the challenges that I indicated at the very beginning, for data sparsity, using methodologies of synthetic text generation, we can generate missing data, the data that it's difficult to collect in reality. For examples, for underrepresented group, to balance out the bias. And also we can use methodologies of synthetic text generation to mimic restricted data, to create some paraphrase, to create some version of the data for which we have to go through very painful long procedure to get access to. So then the synthetic data could also tackle the questions of reproducibility and ethics. Due to this methodology, data could be shared more easily because this is no longer actual patient data, but some variation of the patient data. And due to different techniques of obfuscating private information, the content could be the privacy of the patients could be protected to a certain extent. And then in terms of the interpretability, synthetic data could be used to augment training data in a certain way so that the model will pay attention to certain parts of input that would make sense, for example, to the user and help the interpretability of the models. So let me say, if we want our prediction model to relate its decision to such key phrase as high blood pressure to detect the diagnosis of hypertension, we can generate more examples that contain this key phrase, high blood pressure. And this will help the model to learn this connection and make it hopefully more transparent and interpretable.
Okay.
Yeah.
No, thank you so much. I'm not sure how familiar people are with this space, so it's going to be very interesting. And it definitely got my mind thinking, when you said variations of patient data and augmenting training data, that's kind of interesting from one perspective. And then you talk about privacy and you touch upon that it might be something. It's hard to imagine a hacker wanting to take synthetic data, but I'm going to go there in my mind. But what does the value or, synthetic data, is this going to help us with privacy and protection? Or you could just explain that a bit more.
Absolutely. That's a very valid, that's a very interesting research topic that I'm actually currently working on. So I will also probably show one of the slides. I have slides for
very quickly, because I was naughty again. So quickly.
That's one of the things I wanted to talk about in any case. So basically, in the methodology, I proposed the privacy is controlled through the input phrases. So you can see that the only thing that coming from the real text is the key phrases. So basically, we can filter them out in the inputs and see and establish some rules so that there is no potentially threatening information for the patients. And the second thing is that for training the generation models, they already de-identified data were used. So this how I tackle the privacy problem and in the relation of this particular methodology. But then what we are working on currently is that we're actually working on privacy safe generation models. So there are different techniques now that we that exist in NLP and in general in machine learning community. Okay. So as I said, this could be addressed with pre-processing, and then there are different techniques that reduce the overfitting of the model. Okay. Right? So basically the main danger here, right, when we create this data is that the model while training will memorize the real data, the one that actually is concern the patient privacy in the data that's used for training. So if we do the correct training in terms of overfitting, and we handle the memorization issue with those techniques that I mentioned here, like federated learning, differential privacy.
Okay.
Then they will be very low chance of the model reproducing anything that is related directly to the
Okay. I'm gonna hold you there just because we want to stick to time. But thank you so much for that. It was really interesting. And now we're going to kind of switch the lens quite a lot here and see this from a different perspective, how applications this could be potentially really life-changing and very positive. So our next panelist, Jorge, based on your experience and the work that you're doing at SilverCloud, where do you see the impact and potential of prediction models in clinical settings?
Hi, Becky. Hi, everyone. Well, I mean, I guess just to start things off by saying, obviously the potential is huge, right? I mean, the considerations that I think, especially Lucia and Mandana were talking about, I think really speak to me, and it's considerations that we have taken on board as well as we've been working on this particular project with Microsoft, which I'll share a little bit about. But the potential is huge, right? Because if you can, have a prediction which is quite accurate and feed that back to doctors and to clinicians, and they can use that in their practice as part of this feedback-informed psychotherapy that enhances the chance of someone who would have otherwise not improved or not done better, but actually veered them towards the path of recovery. I mean, that in itself is huge. So the potential is huge that you can have an impact on people who before maybe, the clinician wouldn't have been able to spot this without a prediction model that's taken into account hundreds of thousands of previous cases, even after considering all of the really great points that the speaker said about, the dynamic world that we live in, the ethical considerations, all that stuff. So that is big, obviously, but the impact really is only starting to take shape. So, and I can say that just looking at it from the ground up, it's early days, right? I mean, there's all these considerations. There's the ethical considerations. There's, how does this actually affect the agency and the deliberate practice of, clinicians looking at this prediction, and then what do they do with it? How does it make them feel? But if you do consider all of that, then the impact can be huge at a service level, at an individual level, and at a population level. So having said all that, the particular model that we're working with, we were very careful throughout the course of putting together the model with these brilliant people at Microsoft, which know their stuff. They know machine learning really, really well. And, we wanted to make a model that was obviously accurate enough, but then would only give a prediction when a level of accuracy was reached, so that, you wouldn't ever give a 50-50 prediction. So, like based on the data that I'm seeing and on this individual, their chances of improving are a little bit more than 50%. I mean, that's really obviously can be very confusing to a supporter or a coach. So, and I guess what I need to share a little bit too is that, our platform works in that asynchronous coached way. So, a user will go through their, will go through the program, will go through their internet delivered CBT program in depression and anxiety on their own, and then asynchronously, their supporter will look at everything that they did on the platform, and they'll get this information fed back to them. And then based on that, they'll give recommendations. They're clinically, they'll clinical expertise, and they'll give recommendations back. What this prediction tool will do is that it'll give the supporter an extra bit of information. It's obviously not an end all. It's not, this is what's going to happen. It's, well, in all of these previous cases, similar cases, after a few weeks, your the likelihood of this person improving are X%. And what's interesting, as we've, tested this out, just ran a small pilot and interviewed a few supporters, is seeing the impact that it already has depending on the prediction itself. So I think this hasn't been touched upon, but it is very different if you get a negative prediction versus a positive prediction. So really what we heard a lot is, well, if I see a positive prediction, it really reaffirms what I'm doing, so I continue, doing the coaching that I'm doing. you know, hoping that that will maintain and that this person will indeed improve. It's when they see a negative prediction where they go, okay, maybe I can approach this in a different way. Maybe I can suggest something different to the user. And something that I really liked that I heard is I asked specifically, can you remember a specific case when this happened? And there was one coach that said, yes, you know, there was a negative prediction, and I thought a little bit outside the box, maybe I could recommend a different, you know, tool, a different behavior, something to this user. I did so, and then the feedback that I got was, actually, you know, this really, really helped me. And that was a direct impact of this prediction model being fed back to the clinician. I mean, that they said that they wouldn't have done that unless they had seen that this user was potentially not going to improve. So that's, you know, a real world example of the impact that this can have, obviously. But these considerations definitely have to be taken into account before, you know, you aim for a wider rollout.
Okay, great. Yeah, and it can be potentially quite powerful. The metrics that get fed into the model, and when it's deemed to be a positive outcome, how are the metrics of the service user or the client or the individual factored into making that prediction?
Yeah, so I mean, well, it depends on the model, right? So obviously, you decide what you feed into it. And what we did with Microsoft is that we saw the difference in the accuracy depending on the amount of information. And you'd be surprised that sometimes there is too much that you could put in there. So obviously, being a digital platform, you have the advantage of knowing every interaction that, you know, someone has with the platform. So you have a lot of data with which to work with, right? But not all of it has an impact. And in fact, the largest predictor or, you know, influencer on the model, if you will, again, like, I'm not very technical, so I use very lay terms in this, but it's the symptom progression, you know, so the symptoms that they show during their course of treatment, especially in the early stages, that had a higher impact than the engagement that they had on the platform, although that helped somewhat. But it was the level of symptomatology, not so much the individual symptoms, although that did have a little bit of an impact too. So you feed that in, and, you know, you reach a level of accuracy, also taking into account specificity and sensitivity, because, you know, it depends, just like with any I think any screening tool for something like cancer or, you know, tuberculosis, you want to influence sensitivity over specificity sometimes. Like, you want this model to be able to predict the cases which otherwise would not have improved and identify those, because the worst thing is that you have a prediction model that says this person will improve, but in reality, they don't. And that's, you know, it's a fact. Like, none of it is 100%. You need a gold standard, like it's been said. And that's what you kind of, you know, you build into the model.
Okay, thank you.
But yeah, I mean, it's certainly not easy.
Okay. Okay,
but with huge potential, like I said. Yeah.
Thank you. Super. Okay. So sticking to time again, sorry for these quick transitions. But yeah, it's not perfect. And the accuracy, what does that mean to the individual if it's deemed 98%? You know, how does the person or the service user, et cetera, feel about that? So I want to now transition over to Matt, our last panelist, and we have kind of run behind a little bit, but don't worry, Matt, because we've got plenty of time. And if we have extra time, we'll chuck in some questions from the Zoom, but this is your time. And I just want you to tell us a little bit more about your work and your perspectives.
Oh, okay. Yeah. So, I mean, it's been fascinating to hear the different challenges that are coming up about. So Mandana was saying about the state versus trait kind of, you know, can you tell, is this how this person is now, or how they're going to continue to be, or is this a blip? And one of the things that we've done at the Institute, when we were just looking at if we were going to build a feedback-informed therapy tool, like Jorge is talking about, where, you know, you can reflect on your practice and maybe change it, what would a good explanation being that. And we work with different stakeholders. So we had therapists, service managers, and trainees, and then patients and carers. And really the key thing was that it wasn't, it was understanding not just the individual explanation, but that it was based on a psychological model. So it's not just that the prediction is accurate, but actually it's got face validity for the clinicians. And then the flip side of it was, and this hadn't even been considered, was that should it be shared with the patient themselves? Didn't they have a right to know what judgments or inferences have been made about them, so that they can correct that? And so this whole idea of contestable artificial intelligence, you know, who sanity checks the sanity check? And you know, it's really not being considered. But you were asking for examples of you know, things being inferred wrongly from social media. In my records, there was at the time that my wife and I, we just had our first child, and I was trying to access treatment for mental health problems, and I couldn't. I'd been through a torturous process, and a letter came back, and it said that I was angry, and then in the subnote it said, but he's probably just angry about not being able to access treatment. But the implications of that is that suddenly there's 2 midwives turning up to appointments because they think I'm a threat. How do I get that changed in my notes? You know, so there's, you know, so suddenly then I'm somebody who it requires careful handling, and I didn't even, there's no recourse for that. So I think this is really important. And when we talk about getting to the ground truth about how do we engage the person who the truth is about and see how it relates to their truth. And yeah, there are cases where actually we know people don't always give the same answer, particularly in, you know, in talking to humans versus talking to chatbots. Actually, there's a disinhibition. Actually, they might be more truthful. And you know, if you look at what's happening in the UK at the minute, we've got massive waiting lists for people for all kinds of treatment. If you ask somebody if they're ready for treatment, they generally always say yes in that self-report, because they don't want to miss out even if they're not ready. So I think it comes back to this triangulation issue. And this is where, as Lucia said about, you know, having the human in the loop. So this isn't a foregone conclusion, but actually that it's augmented intelligence. But who is the decision maker in this process? So I think, you know, this is fascinating. This is where, as we said about the multidisciplinary approach, bringing in the humanities, who've already grasped a lot of these issues about things like epistemic injustice, about whose knowledge is valued in this situation, and you know, we've talked about data sparsity and data poverty, and we can do approaches like generating synthetic data and smoting it so that we've got more examples. But actually, if you've hardly reached those communities that you're lacking data on, the onus on you as a scientist is to take the effort to get out there and talk to them and work with them to gather that data with their permission, so that you've got models that work for them, built with them. So you know, this is you see this a lot in particularly in natural language processing. The competitions every year where people are just trying to beat the benchmark by tweaking the models and coming up with the new techniques, and it's so distant from what the consumer would understand. And Jorge was saying, you know, you don't want to let people fall through the cracks, because the danger of saying somebody's well when they're not well is such a big difference. But the focus of the field is so much on fixing the data and the techniques, and not actually engaging with the people. And there's, you know, Jorge's colleagues at UCD are really good around the HCI elements. this, and so yeah, it's bringing the people back into the room, and so this is you know, why I love this DIMH conference, because it's about bringing those different perspectives into the room. I think there is such potential in here for each of these predictions to be teachable moments for people. I mean, Jorge said about how it might affect practice of the supporters, who are people with mental health as well. And, you know, if you've been told you're not good at your job, or you could be doing it differently, how do you phrase that? But yeah, it was still got a them and us about this, about actually the end users are part of this system, and why are we excluding them from all this information that's about them. Sorry, that's a bit of a rant, but I'm just very passionate about this.
Matt, it was awesome. It was absolutely awesome. And you drilled down into specific issues. So I thought that was amazing. And another kind of human factor perspective I've just seen in the chat. So I'm going to segue, but stay with you on this human perspective. This is raised by Beth. So does the prediction model ever make therapists disheartened by the results? So you sort of went there and touched on it, but let's go deeper with this. And if anyone wants to speak to Beth's comment, go for it. And Matt, if you're on a roll, so starting with you.
Yeah, so there's a great piece of work done by Tim Althoff and Dave Atkins recently on empathy in online support communities. And their result was that only 1 in 6 conversations were actually empathetic. You know, and I'm biased about online support and peer support, and I was thinking, oh my gosh, you know, how would a clinician recommend this kind of intervention to somebody if they think that the people are just going to get you know, the still face or made even worse? And so yeah, some of it is about the definitions and recognizing that this is a learning process. So I think we've got to be really careful about the impact of the outputs of these models, because the outcomes are where you add in the human factors again, and that's not as predictable. Yeah, I'd love to hear from the other people on the panel about this.
Yeah, I mean, I responded a little bit in the text, but I agree with everything you say, Matt. I think one of the things that we're excited about for the trial that we're going to run in the NHS as we try this model out is precisely the effect on the supporters, because, you know, how is this affecting the way you do your practice? What do you think about it? How did it make you feel? What was your acceptability of it? You know, did you understand it? You know, how did it change the way you think about specific cases? So that would be a big part of it. And then the impact on the service and about how much you talk about cases with peers or with your, you know, service managers. And the other thing to say, which is something that you mentioned, Matt, as well, is, you know, the language as well that you use. We did also we published an interesting study looking at the language that supporters used, and found sometimes unsurprising things that, you know, like the more positive you framed the message, you know, it did lead to better outcomes. Like there was actually a direct relationship, but it was also talking about social relationships that had an effect. Also like shorter messages. So, you know, a bit to the point, but very empathic, positive, and also talking about social aspects, you know, and all of that played a role in positive outcomes. So it really is about what you say, but it's about taking care of the supporters too, for sure. And, you know, how is this information going to be presented to you is important as well. And so, you know, we've run some interviews and asking them how you would like to see it, you know, like very much, you know, at the top as a headline, or like to one side, like every little detail, because it's the supporters after all who are doing the work, right? And they're using this very important backend of the platform.
Yeah, and Jorge, I mean, I talked with Prerna Chikasal about that work, and it's brilliant. And one of the fascinating things is that some groups of people, it's the opposite is true. That so it's not just what is a good message, but it's about how do you personalize that for the end user. And I think this is just a huge issue. We've managed to scale up mental health with technology, but as that quantity increase come at the cost of quality, and this is the next kind of dimension that we really need to dig into. And how do we improve that, but in a way that doesn't disenfranchise people or discourage them from engaging? There's I know in SilverCloud you've got the supporters and the coaches, and then a lot of the other online forums, the super users are doing the heavy lifting, and they're not staff, they're just other patients generally who've been around a bit longer, but do a lot of that social capital work of the bridging, bonding, linking. So yeah, how can we help them without taking away the gift of giving?
Thanks, Matt. I'm just going to let everyone know that we've only got a few minutes left. We've got a hard stop at 12. But Julia, Lucia, Mandana, is there anything that you would really like to add, a passionate last thought for us?
Well, first, I really enjoyed this. And Matt, I really admire your passion. I think we need people, of course, like everybody on this panel, but specifically like Matt, who bring that human element, the voice, the lost voice of people. I think one of the things that concerns me, and I think it's really important for all of us bear in mind when we try to bring technology into this field that is very human, is we don't see people when they are behind their phones and we are on the other side, connected to each other via a computer. We don't see what we're doing. And it's difficult to get those feedbacks that exist when there is a human-to-human interaction. Like the therapist sees what they're doing, like, oh, this is not going well. So they quickly adjust and do this. But that is a signal that is getting lost when people on their phone. So, and it's very difficult. It becomes a question of something that people are vulnerable when they seek mental health support. They're very vulnerable. We're asking them to trust us, to be vulnerable. And then we tell them we're going to judge you and tell you things. And this means we have to always ask them. They are the ones who need to take the lead on whether that judgment is correct or not. And I think this is something that is missing. Like people, we need a bit more empowerment for people who seek support, rather than telling them we know what we're doing. Because the reality is that we don't know. Even the therapists don't know. They tried, like there are a limited set of clinically proven techniques that work for some people sometimes, but majority of people, we don't know. I mean, human mind is the universe, and that is undiscovered. We know more about space than we know about human mind. So I think it's important to be a bit more humble and to keep that in mind when we deal with people, especially when it comes to ethics and when we bring technology into the field, to give more power to people who share their data and vulnerability with us.
Thank you so much. And on that note, I think we can end a conversation that went from highs and lows, and we're ending on a nice high. So thank you all prediction models and metrics panelists. And yeah, just thank you for your time, and delegates who enjoyed this session. Okay, and join us for the next one.
Thank you, Vicky. Bye.
Thank you, Becky.
Bye.
Thanks, everyone. Bye.
Bye.